All right, I'm going to begin evaluating my images. This first image is the AP projection of the knee, and I had a tube angulation of 3 to 5 degrees caudad. This will open up that joint space between the femur and the tibia, or the femorotibial joint space. So I would say that my patient was properly positioned. And some of the criteria for a AP projection of the knee is that it is properly collimated, and it is. There's about an inch of space on either side, and from top to bottom there's about 2 inches on either side of the knee joint. My patient's knee was fully extended. They were able to do that. Sometimes they cannot. You can see the entire knee without any evidence of rotation. As I said, the femoral condyles are symmetric, and the tibia intercondylar eminence is centered. There is the normal slight superimposition of the fibular head. Her tibia was just fine. The patella is superimposed on the femur, and there is an open femorotibial joint space. And the interspaces are equal on either side, and you can see the soft tissue and the trabecular detail of her bones. So all in all, this is a good image. You can see my marker on there, and that covers the AP projection of the knee. Okay, the next image that I did was the AP oblique projection with medial rotation. You can tell by looking at this image that it's properly collimated. I have my marker on there. You can see a slight separation between the tibia and fibula at their proximal articulation, which makes sense because it's a knee. You can see some of the posterior tibia there in that joint space of the femur and tibia, and you can see the lateral condyles of the femur and tibia very well, and both plateaus, and you can see that the patella is slightly beyond the surface of the femur there on the medial condyle. So it's you can tell that that's from the medial rotation, and the knee joint appears open, and you can see all the soft tissue around the bone, and you can see the trabecular detail of the bone as well. I took off the 5 degrees of caudad angulation in my central ray because that's what we do at our clinic, but I know that that is a requirement of Merrill's, so I just wanted to make mention of that. And let's see, that wraps up my AP oblique projection with medial rotation. All right, then I started on my medial-lateral projection of the knee. Positioning for this one is key, and so is the 5-degree cephalic angulation of the tube, which I had, and that's clear in the image. And then for positioning, it's important to not have your patient over-rotated or under-rotated, and to have them flex their knee 20 to 30 degrees. That puts them into the true lateral position, and it helps to demonstrate the femoral condyles as superimposed. So that's really important. Under rotation can kind of throw them on one side or the other of each other. So let's see. So you can see that it's properly collimated. Her knee is flexed 20 to 30 degrees. You don't want to do that if you suspect a fracture. Then you'd only have them flex about 10 degrees. The fibular head and the tibia are slightly superimposed. The patella is in lateral profile, so that's good. And you can see the open patellofemoral joint space. You can see an open joint space between the femoral condyles and the tibia, which is also really important, and you can see the soft tissue and bony trabecular detail of the knee. So this image was properly exposed. You can see my marker was on there. And this concludes my evaluation of the medial lateral projection of the knee. I would say that this is a acceptable image, and I would send this one off. All right, so then we moved on to do the apiaxial projection of the intercondylar fossa, which is also known as the Beclaire method. And let's see here. So you can tell that it is properly collimated. My marker is on the image. You can see the open intercondylar fossa. You can see her intercondylar eminence centered there in that joint space. There's no superimposition of the patella's apex over that fossa there, and you can see that there was no rotation of her anatomy there by that slight overlap of the tibiofibular joint there. And you can see the soft tissue and bony trabecular detail of her knee, and you can see that the central ray was perpendicular to the long axis of her lower leg. It entered 1/2 inch below the patellar apex, and you can tell it looks pretty centered in that area there just by looking at this image. So I would send this image off too. This looks great. All right, Danny, we've reached my final projection. Finally, the tangential projection of the patella and patellofemoral joint, also known as the Setagast method, and one of the more frequent exposures taken at the site that I'm at. So we're almost done. There is evidence of proper collimation, and my marker is on the image. You can see the patella in profile, the femoral condyles and intercondylar sulcus is also visible, and you can see the open patellofemoral articulation and the soft tissue and bony trabecular detail of the anatomy. Hurrah! This image was taken with my patient's knee flexed about 15 to 20 degrees. I didn't really have her flexors a whole bunch, and I did not get the collimator to 40 inches because that's really hard to do. It's a little bit more SID than Meryl's would like, but you know, it turned out great. Look at this beautiful image. So we are done, and thank you very much. Okay.